and I'd like to thank the organizers of the AIUM for inviting me to speak today on surveillance of cardiac lesions that may progress in utero. I have no disclosures to make. I hope by the end of the talk that we'll be able to understand the indications of serial echo assessment for fetal cardiac disease. Also, we will be defining the in utero progression for selected fetal cardiac anomalies. And then hopefully by the end, all of us here will be better at performing targeted echo assessment for selected fetal cardiac disease during its progression in utero. So the fetal myocardium is less compliant than the adult myocardium, which accounts for its inability to handle loading conditions in the fetal environment. The fetal myocardium also produces less active tension and maximal force compared to the adult myocardium for various reasons. First of all, the myocytes themselves are immature. There are fewer contractile elements, as seen on the right of the screen by electron microscopy of the fetal myocardium, compared to the adult myocardium. Also, there are decreased T-tubules in the sarcoplasmic reticulum, making the release and storage of the calcium stores during active contraction inefficient. And then finally, there's decreased sympathetic innervation and beta-adrenoreceptor concentration, making the fetal heart less responsive to adrenergic stimulation. The fetus really lies at the top of the curve of the Frank-Starling curve, as seen here. This really limits the capacity for it to increase stroke volume with increasing mean arterial pressure throughout gestation. And so the heart rate really becomes the most prominent means to increase cardiac output. And keep this in mind as we go through and discuss these specific lesions today. Now, there are various reasons for performing repeat fetal echocardiography throughout gestation. First of all, it helps us understand the nature and the severity of the lesion, and development of signs of heart failure can be detected as well. It gives us a way to track the natural history that's anticipated of each fetal cardiac lesion, and the opportunity for prenatal intervention, even planning for perinatal intervention if needed. And then finally, as we've all experienced, during one scan, the fetus may be in a challenging position, and a repeat evaluation may help us really complete that cardiac evaluation. So this is a huge list of, that defines the mechanism of progression of fetal cardiac disease, and again, as outlined by the AHA scientific statement in 2014 by multiple people, even in this room. But today we're going to be speaking on just 5 of those mechanisms, and we're going to be looking at the progression of valve insufficiency resulting in ventricular dilation, progressive valve obstruction, development of cardiomyopathy complications when detected in utero, also discussing restriction of the foraminal valley related to hypoplastic left heart syndrome, and then development and progression of cardiac tumors and their complications. So I'm going to use absent pulmonary valve syndrome as our lesion to discuss progressive valve insufficiency. Dr. Freud, after this talk, is going to be talking about Epstein's anomaly, so I left that one to her. So absent pulmonary valve syndrome is described as rudimentary dysplastic pulmonary valve leaflets with progressive stenosis and regurgitation. It's most commonly associated with tetralogy Fallot, but can be seen with intact ventricular septum as well. And the agenesis of the ductal artery increases the RV afterload and hemodynamics. And as you can see here, you have this dysplastic pulmonary valve leaflets resulting in a two-flow pattern across that pulmonary valve with pulsatile dilated branch pulmonary arteries that can lead to various complications in this condition, even in utero. There have been several studies that have looked at absent pulmonary valve syndrome in the fetus. Dr. Moon-Grady in 2002 published on 5 fetuses, 4 dying in utero, and all of those patients were hydropic. Dr. Inamura in 2005, again, found a mortality predictor of right ventricular dysfunction with increased Tay index in his study. Dr. Zwast in 2014, from the CHOP data, looked at 21 fetuses and found that LV dysfunction was a mortality predictor. And then Dr. Kawazu in 2015 looked at 9 fetuses, and again, hydrops and polyhydramnios sorted out to be mortality risk factors. So let's look at a patient here together. So you can see that there's a dilated dilated pulmonary artery. You can see This heart in general is enlarged. Both ventricles are enlarged. You can see the two-flow flow again across the dysplastic pulmonary valve, confirmed by spectral Doppler. And that cardiomegaly is showing us here that we had a CT cardiothoracic area ratio of 0.6. Also, along the lines of evaluating this fetus, we noticed that the tricuspid valve inflow pattern was monophasic. And at 22 weeks now, this patient's lesion has progressed. We can see a mediastinal shift rightward of this fetus. The RV is dilated and hypertrophied. You can make out that VSD here as well in this tetralogy of flow variant of absent pulmonary valve syndrome, a massive main pulmonary artery. When you look at the short axis, you can see both the right ventricle and left ventricle have dysfunction. And then you can see the pulsatility in the umbilical vein as well with this condition. What I also thought was interesting was that the echogenic nature of the left lung was different than the right lung. And this was actually nicely described by Dr. Yagi and colleagues in 2013 during a collection of absent pulmonary valve syndrome patients that looked at a similar finding here, where again, there was an echogenic left lung, presumably due to that dilated main pulmonary artery with compression of the left bronchus. Again, just shown here in our patient and shown here on autopsy of their patient in 2013. So at 26 weeks gestation, unfortunately, the patient underwent or experienced in utero demise, and you can see the evidence of high drops at that point in time when she showed back up in our office. So was this predictable? Well, during our counseling sessions, yes, we did talk about the poor outcomes, but really putting this all together in 2013 when we had a multi-center study, Dr. Chilia and various centers that participated in this, including Phoenix, looked at various parameters by echo that could predict early mortality with absent pulmonary valve syndrome. And when you look at this, mediastinal shift had a significant association with fetal death, or postnatal death as well. Moderate to severe RV dilation, LV dilation, cardiothoracic area ratio, and both right and left ventricular dysfunction. So in our fetus that we just examined with this, we saw the progression of disease, and now we can correlate that again with early mortality in this condition. So let's move on to talk about progressive valve stenosis, and we'll use the lesion aortic valve stenosis to discuss this. So look at these two images. Is this evolving aortic valve stenosis? I challenge you to say, based on this, it doesn't look too bad. We have a left ventricle that looks normal in size. The wall's not thickened. Both ventricles appear to have good function. Even the atrial septum a little bit in this view seems to be bowing right to left normally. And there's just a little bit of turbulence of flow as it crosses the aortic valve. And when we pulse a little bit higher across that aortic valve, we can see that the aortic valve velocity is 1.5 meters per second versus the ductal artery 0.73 meters per second. And that difference subtly between the aortic valve and the ductal artery is a tip-off that this could be early signs of aortic valve stenosis. And so use that in your armamentarium when you're screening. So this patient postnatally did have a bicuspid aortic valve. You can see that here on the left of the screen, and then the doming nature of the aortic valve and dilated ascending aorta. And here, this is the baby's first postnatal echo. You can see the turbulent flow across the aortic valve with that initial peak gradient of 37 millimeters of mercury. By 2 months of age, our peak gradient was 93. And mean gradient 47. This patient underwent successful balloon aortic valvuloplasty and is doing quite well today. So Dr. Yamamoto and Hornberger in 2012 really did a nice job describing natural history of multiple lesions, including aortic valve stenosis. And just walking through that, moving on from that early marker of velocities differences across the aortic valve and ductal artery, we move on into signs of LVH with increased aortic valve velocity, LV dilation and development of mitral regurgitation, then systolic and diastolic dysfunction of the LV with endocardiofibrillar elastosis. This results in decreased LV compliance, and therefore actually we have decreased antegrade flow across the aortic valve. As that happens, we develop retrograde aortic arch flow, and that dilation of the left heart structures will compress the right ventricle and the right atrium, and that will actually even change our dynamics of the atrial septum as well. We'll have a rightward shift of the septum primum towards atrial septum and reduce flow across the left atrium with increased, across the atrial septum with increased left atrial pressure and endocardial fibrinolysis of the LA. And then this change on the right ventricle with that ventricular-ventricular interaction will increase CVP and have inadequate cardiac output. Our pulmonary veins will dilate with altered lymphatics, which can eventually lead to high drops and fetal demise. So let's look at a case of this happening. So at 23 and 2/7 weeks, you can see that this patient on its initial echocardiogram in our office, had a dilated, poorly contractile left ventricle. You can see the left atrium is enlarged, and same view here rotated for us. You can see that there's mitral regurgitation as well. But otherwise, the right ventricle appears to be okay. Same gestation, same study. You can see that turbulent flow across the aortic valve, and even though this isn't a great lineup, peak gradient across that aortic valve already with increased velocity of a peak gradient of 35 millimeters mercury. The atrial septum at this point also had restrictive atrial septal flow. There's not much motion of this atrial septal wall. Again, that fixed septal wall motion is another marker to be aware of when we're looking at aortic valve stenosis and other forms of critical left heart obstructive lesions. And then there's retrograde flow in the aortic arch, both confirmed by color and spectral Doppler. Well, 4 weeks later, actually, I'll stop there. At that point in time, the patient was offered in utero intervention and presented to a center for fetal cardiac intervention. But the lady's BMI was 39, and at that point in time, the cutoff was 35. My understanding is that cutoff has now moved up to 45. Heard it from Dr. Turetsky himself. And so this patient was actually, we looked at other centers, but she wanted to continue the pregnancy, but no in utero intervention was offered. So here's our next stages in those. In that pathophysiologic mechanism that I showed you earlier, you can see the left atrium, left ventricle are dilated and compressing the right heart structures. And I'd say that function of the LV is worse now, if it could have gotten any worse. And you can see evidence of EFE. And you can see that there's also development of a pericardial effusion. And there's significant mitral regurgitation, which is worse, but the left ventricle still was able to generate a mitral valve regurgitation Doppler pressure of 42, so that LV still actually had some ability to generate some active systolic force, but the patient did start to develop ascites, and we saw her back as a scheduled follow-up visit, and again underwent in utero fetal demise. So the pathophysiology, again, when you look at that same paper, was really nicely laid out in terms of what happens with these patients with severe aortic stenosis or pulmonary stenosis, and you can see the pathophysiology as it leads down, illustrated by this patient, a progression of disease of this patient with aortic stenosis. So I want to just say, this is all well known, and we'll just mention it, that aortic valve stenosis can progress to hypoplastic left heart syndrome, but not every single patient does, obviously. You can see, again, this boggy, poorly contractile left ventricle with endocardial fibrinolysis here in the short axis as well. You can make that out, how poor that function is. And there was monophasic Doppler inflow pattern across that mitral valve. So at 19 weeks, is this evolving HLHS? Well, the answer is yes. At 24 weeks, when we saw her back, again, we saw that LV had shrunk down, and this patient went on to require single ventricle palliation postnatally. So when we see a patient with aortic stenosis, we want to be looking at multiple factors, the mitral aortic valve LVZ scores, systolic function, diastolic function as well by those parameters, and looking also at pulmonary venous Doppler patterns, the direction of the flow in the transverse arch and the foramen valley, presence of EFE, and then looking at the aortic valve and mitral regurgitation pressure gradients. And there have been studies that have looked at these, and I just quoted here from 2006, those factors that we've already seen by echo, that those patients with these findings are more likely to evolve into HLHS with the retrograde flow in the transverse arch, left to right shunting in the foramen valley, and monophasic mitral valve inflow pattern, as well as significant LV dysfunction. But those patients that are going to undergo fetal cardiac intervention, looking at these parameters, whether an LV long axis or short axis Z-score greater than 0, mitral valve annulus, aortic valve annulus Z-scores as well as listed there, or the mitral regurgitation or AS gradients greater than or equal to 20. When you look at a threshold score of 4 of the 5 parameters listed there at 100% sensitivity with 53% specificity to actually be successful as a biventricular repair post-intervention. So I'm going to move on to another lesion, fetal cardiomyopathy and progression of the disease complications related to cardiomyopathy. About 10% of cardiac disease in utero is accounted by cardiomyopathy, with 3% postnatally. So there is a significant fetal loss. The etiologies include familial, metabolic, infectious, immune-mediated, fetal anemia, aortic or ductal arch obstruction, but most common, idiopathic, is what we see. And it's important to look at the dilated versus hypertrophic cardiomyopathy seen in utero, with mortality risk factors for both being significant systolic and diastolic dysfunction, AV valve regurgitation, and high drops. In those patients with dilated cardiomyopathy, the left ventricle and high drops have a very poor prognosis. Dr. Jim Huda developed the cardiovascular profile score, which we should all be very familiar with, which is a 10-point scoring system under 5 different criteria listed there. In 2008, he collected 131 fetuses with various cardiac lesions, and 26 of those 131 died either in utero all the way to the post-procedural surgical time frame. And again, the specificity of this scoring system for predicting a 5-minute APGAR was 0.98 with a mortality at 28-day mortality specificity of 0.99. So patients with a cardiovascular profile score 7 or lower had an increased mortality to those 8, 9, or 10. Right heart lesions had the lowest cardiovascular profile score with the highest mortality, and independent predictors included high drops and cardiothoracic area ratio. So here's a patient at 24 weeks gestation that we followed in our office. It's not subtle, with a dilated LV, and you can see that those aortic valve leaflets are barely opening, and there was very minimal flow actually across that aortic valve. When you look here, the mitral valve is not hypoplastic. And there was really no significant mitral valve regurgitation at that point in time. There was monophasic pattern across the mitral valve, so we took off a point there. Also, the shortening fraction was 17%, so our shortening fraction was less than 0.28. So we took off another point. And we also added up across the gestation at 28 weeks now, noticing that our cardiothoracic area ratio is probably even greater than 0.6 as it sits in this thorax. And we did develop mitral regurgitation as well. So when you look at all of these together, our cardiovascular profile score was 4, accounting for the Doppler anomalies of the umbilical vein and also ascites. So this patient had a very poor outcome anticipated, and we ended up counseling this patient as such, but again, the family's desires to continue the pregnancy and doing everything they could, even postnatally, to help their fetus. We continued to follow them with a finding at 31 weeks gestation where we had stasis of blood within the left ventricle and development of this echogenic structure within the LV. And we traced it here really nicely for all of us to see that that was actually development in LV thrombus. At this point, we've talked about transplantation options versus comfort care, and the family wanted to continue to pursue those transplant options and had to meet the transplant team even prenatally. They weren't listed, but work was done prenatally. And here's our postnatal evaluation again, showing that boggy LV with that mural thrombus as well. And so actually this patient actually has a pretty happy story at 6 days of age, became the youngest U.S. heart transplant recipient. And here's the explanted heart on the right of the screen with that mural thrombus along the thin-walled LV, which was quite dilated. And here on histology, there are vacuoles in the myocardium with fibrosis without any inflammation, and the thrombus being adherent to the endocardium. So we're going to shift gears again. We're going to talk about restrictive atrial septum related to hypoplastic left heart syndrome. Again, a very quick, easy review for all of us. There are 3 natural shunts within the fetal circulation: the ductus venosus, foramen ovale, and the ductus arteriosus. And that foramen ovale is critical to allow the oxygenated blood from the umbilical vein going across there from the right to left atrium to allow for growth of those left heart structures. And when we have early gestational restriction at the foramen ovale level, that can lead to hypoplasia of the left heart structures. And once we've developed hypoplastic left heart syndrome, restrictive atrial septum will limit the egress of pulmonary venous blood from that left atrium, which can lead to pulmonary venous hypertension and negative impact on the lungs. So when you're evaluating this in utero, it's important to look at the atrial septum and characteristics and development of this, and this is a dynamic process we see in utero, but really looking at either if there's a restrictive atrial septum by the foramen ovale with color flow aliasing, a fixed atrial septum, which means the angle between the septum prime and secundum is less than 30 degrees, or the flat atrial septum where there's no mobility of the atrial septum at all. And this is just an example of a patient with hypoplastic left heart syndrome with an intact atrial septum with no flow across there by color. So not only that, at the atrial septal level, we want to be assessing pulmonary venous assessment, where we can look at just by 2D the prominence of the pulmonary veins that are engorged, and even by here just color Doppler alone, seeing that color flow reversal in the pulmonary veins. And so looking across gestation for the same patient at 20 weeks, then 24 weeks, and then 27 weeks, you can see that restrictive nature of the atrial, of the foramen ovale, both here at this, or right here at the superior aspect of the bulging atrial septum, going from the left atrium into the right atrium, and the pulmonary veins are quite prominent. And looking at the velocity time integral of the forward to reverse Doppler assessment from 20 weeks all the way to 28 weeks, we can see that that ratio is actually dropping and falling from 5.5 to 2.6. Dr. Lowenthal, Moon-Grady, and colleagues in 2012 said really any A-wave reversal at this point in time across gestational age shows increased mortality at 2 years of age with hypoplastic left heart syndrome. Dr. Michael Felter actually published 2 great articles. One that he followed up looking at that ratio of the VTI of the forward to reverse flow in the pulmonary veins with hypoplastic left heart syndrome of those patients that were suspected to have restrictive atrial septal physiology versus non-restrictive. And he moved the cutoff down to even less than or equal to 3 as that forward-reverse ratio to see if we're missing anything, comparing those less than 5. And really, based on surveillance, using that new cutoff of 3 is when he advocated for in utero intervention and surveillance echocardiography throughout gestation. It also helps with delivery planning, determining and depending what your delivery strategy planning is in your center, to alter that depending on its risk for need for emergent atrial septostomy postnatally, being high risk for those patients with a VTI ratio, forward to reverse ratio less than or equal to 3 versus a low risk when it's greater than 5. So there are criteria for fetal intervention with hypoplastic left heart syndrome with restrictive atrial septum. It's always good to quote your colleague that's going to be coming up to the stage next, so Dr. Freud, where basically when you look at intact atrial septum or foraminal valley that's small, looking at the prominence of the pulmonary vein reversal and that VTI ratio. And here's a patient that was just an interesting finding that underwent potential in utero intervention, but the stent actually is hanging out here in the right atrial wall. So we had to follow this one post intervention, did develop a pleural effusion, but had a successful delivery. But due to that intact atrial septum, this is the one that I showed a few slides ago. Did not survive past 4 weeks. There was significant lymphatic channel disorder in this patient. So final lesion that we're going to talk about are primary cardiac tumors. They account for 0.1% incidence in utero, and from most to least common, rhabdomyomas, teratomas, fibromas, and meningiomas. And here's just a postmortem exam of rhabdomyoma in the ventricular septal wall. Here's another one up here, in the free wall, and then in the ventricular septum, and histology of rhabdomyomas in the heart. Obviously, they're associated with tuberous sclerosis 59 to 79% of the time, and there's a biphasic growth pattern within the fetus, increasing to about 20 weeks and then up to 32 weeks, and this is from experience at large centers, and it is more common to occur with tuberous sclerosis, as published by Dr. Chow in 2008. 50% of these will regress, at least partially, within the first year of life, and the negative predictors of outcome as a neonate included larger tumor size, being greater than 20 millimeters, fetal arrhythmias, and high drops. They did not assess if there was a negative prediction or the effect of flow obstruction with cardiac rhabdomyomas. So here's an example, again, not subtle, of a patient with cardiac rhabdomyomas. You can see the one in the right ventricle, and then this other one in the left AV groove right there as we sweep through. At this point in time, by spectral Doppler assessment, all we really had were premature atrial contractions, as shown right here. We saw the patient back 2 weeks later. And again, we saw continued PACs on this fetus, but halfway through the study, this occurred. And presumably this was related to a reentry pathway in that AV groove cardiac rhabdomyoma that set this patient up for supraventricular tachycardia, as seen by M-mode confirmation. And this patient was going in and out of it throughout the entire study at 38 weeks with a break in SVT, as documented here in this M-mode tracing. Patient's doing well. He's 2 years old. I get to follow him. He's just on propranolol postnatally. And yes, he does have tuberous sclerosis, and his seizures are well controlled. Final case at 25 weeks gestation. You can see we do a 2D sweep and then a color sweep to follow on all of our patients when we start fetal echocardiography. And you can see on this first sweep all the way up from the stomach to the 3-vessel view, you can now see that there's a very large rhabdomyoma in the left ventricle. And then by color, when we get up to that 3-vessel view, you can see that there's retrograde flow in the aortic arch and that transverse aorta right there. And that really had us go searching for what type of obstruction to flow was this cardiac rhabdomyoma causing. And there was unobstructed flow across the mitral valve, actually, as you see there. Further evaluation at that same gestational age, you can see that very narrowed left ventricular outflow tract by that cardiac rhabdomyoma and almost parasternal long axis view, resed up here on the left of the screen as well, where that's just a very narrowed outflow tract. And it was significantly limiting outflow from the heart with that retrograde aortic flow seen in the bottom corner. At 33 weeks gestation, I just skipped ahead here throughout gestation for sake of time. You can see that LV is taken up mostly by that left ventricle, at least in the outflow tract I'm sorry, the LV is taken up by most of the rhabdomyoma around the LVOT, and you can see how closely it's approximated to the aortic valve leaflets. The atrial septum has bidirectional motion, as well as confirmed by color with bidirectional flow across the atrial septum, with indicating increased pressure in the left heart. Postnatally, you can see that the LV is moderately hypoplastic with the right ventricle forming the cardiac apex, and again how closely approximated this was to the aortic valve leaflets, both in the apical view and then along the parasternal long axis view. The patient did have an amniocentesis that's confirmed the TSC1 gene, consistent with tuberous sclerosis, and we thought we'd take a novel approach in our institution and did a hybrid procedure, thinking that because this cardiac rhabdo was so closely approximated to the aortic valve that it may be difficult to get good tissue planes to resect it at this point, and we would bank on the regression of the tumor. And so we did a hybrid procedure. And what is that? Well, it is where we put bands on the pulmonary arteries, and then we put a stent within the ductus arteriosus to essentially have the antegrade flow across the pulmonary artery into the aortic arch across the ductus arteriosus as our systemic outflow. And here's postnatal evaluation by echo of the stent in the ductus arteriosus with retrograde flow in the aortic arch and these pulmonary artery bands on the PAs. So here's my summary slide that just basically summarizes our 5 lesions that I decided to pick up of lesions that may progress in utero and those important echocardiographic factors that we assess throughout gestation. Thank you very much.